My name is Dr. Anver Kamil. I'm Consultant Nuclear Medicine Radiologist at the University Hospitals of Leicester, and this series of talks is covering nuclear medicine and PET-CT. The objectives of this talk is to provide you with an understanding of the basic scientific principles of nuclear medicine and PET-CT, and to help you appreciate the range of clinical roles nuclear medicine and PET-CT have with inpatient investigation and treatment, and will hopefully provide you some skills in basic interpretation of commonly performed procedures. So what is nuclear medicine? Well, nuclear medicine is a medical specialty that uses radioactive tracers, otherwise known as radiopharmaceuticals, to assess bodily functions, to diagnose and to treat disease. So when we think of nuclear medicine, it is best to think of it in three main categories. The first is imaging. So by using radiopharmaceuticals, we might be able to image biokinetics of particular molecules of interest using a gamma camera, for example, to investigate bone metastases with a bone scan, or perhaps to investigate cerebral hypermetabolism when investigating for Alzheimer's disease. The other component is non-imaging. Essentially, this involves using patients' bodily fluids such as blood products that have been radio-labeled with an isotope in order to ascertain certain parameters such as blood volume measurement, glomerular filtration rate, and even bile acid malabsorption studies. And the third component is therapy. This involves using highly radioactive radiopharmaceuticals to effectively treat certain conditions such as thyroid cancer or even neuroendocrine malignancy with very radioactive beta emitters such as lutetium dotatate or iodine-131. It could even be used in treatment of benign conditions such as thyrotoxicosis. But the main component of nuclear medicine is that the patient is essentially the source of radiation. The radiation that is beamed from the patient can then be detected by a camera, and from that we can gain our images. Whereas conversely, with conventional imaging such as X-ray or CT, the radiation source is from an external machine, and the radiation that is beamed onto the patient externally in order to create our image.
Another fundamental concept of nuclear medicine is that we are labeling a compound of interest with a radioactive isotope. Once this is introduced into the patient, it can be used to image a specific pathophysiological process. In this example, we have labeled a molecule called octreotide with an isotope called indium-111. Octreotide has an affinity for somatostatin type 2 and type 5 receptors. These are expressed in neuroendocrine cancers, otherwise known as carcinoid. Once we inject this radiopharmaceutical, if there are carcinoid cancer cells, then the octreotide should attach to them, in turn taking the indium with them. As we can see in this example, there are lots of liver lesions showing uptake. What this represents is radiation being emitted from a radioactive indium isotope, which we have attached to the octreotide molecule, which has attached itself to the carcinoid cancer cells, and so we are able to diagnose carcinoid liver metastases.
And we can use this in a range of different clinical applications such as imaging cancer, assessing myocardial disease, and even investigating neurodegenerative disorders. So how is a nuclear medicine scan acquired? Well, essentially it involves creating the radiopharmaceutical in a lab or a radiopharmacy. And once the radiopharmaceutical has been manufactured in a very hermetically sealed radiation safe environment, it can then be introduced into the patient, either via an injection, inhalation or ingestion. Once time has been given for the radiopharmaceutical to biodistribute around the patient's body and the patient has become suitably radioactive, they would be placed inside a gamma camera, which may be composed of 2 or more detectors either side of the patient. The aim of these detectors is to capture the radiation that is now being emitted from the patient. This may take as long as half an hour and in some cases even up to an hour, depending upon what we are trying to image. And once a suitable number of gamma photons have been detected, we are able to formulate our nuclear medicine image. And this is one of the main principles behind the process of acquiring nuclear medicine imaging. So here is one in practice. This is a whole body technetium bone scan, which is in essence a whole body skeletal survey. It is designed to assess sites of increased osteoblastic activity. And one of the main indications in which we do a bone scan is to investigate for the spread of bone metastases, particularly in patients who have prostate or breast cancer. Identification of a bone metastases is quite important in patient management because if there is a bone metastasis, the patient may not be able to have more radical treatment such as surgery and may have to have more systemic treatment such as chemotherapy. So the detection of bone metastases is quite important in patient prognostication and management. A bone scan is quite sensitive at picking bone metastases, more so than other conventional imaging such as perhaps CT or X-ray. And it also provides a whole body survey as opposed to, say, a CT that might only focus on a certain aspect of the trunk. So to detect bone metastasis, we rely on the increased osteoblastic activity that may apparent at a metastatic site. Essentially, an osteoblast is a cell that is responsible for building bone. There is always osteoblastic activity happening in the bones, but if the bone is disrupted by, say, something like a fracture or a destructive process such as a metastasis or cancer, there may be an increased recruitment or accumulation of osteoblasts at that particular site. Osteoblasts like to eat a lot of a compound called phosphate. So we take a phosphate compound, which we call HDP, and we label it with a radioactive isotope called technetium-99. And we inject that into the patient. And what we would hope to see is the osteoblasts will eat this radioactive phosphate and hopefully light up on the scan. So as you can see on the left is a normal bone scan, and on the right you can hopefully appreciate this is an abnormal bone scan with many hot spots throughout the axial and the proximal appendicular skeleton, including the spine and the pelvis and the ribs. So these hot spots are essentially bone metastases. They're sites where there is an increased recruitment of osteoblasts that have eaten this radioactive phosphate that we have given, and so acting almost like a homing beacon, we are able to visualize all the sites of uptake and disease. One of the limitations of conventional nuclear medicine, however, is that while it is quite sensitive, it sometimes isn't very specific. As we mentioned, there are several other things that can also cause increased uptake on a bone scan, not just metastases, but potentially fractures and degenerative changes. Obviously, the distribution of uptake on this is more typical of bone metastases, but you would still want to correlate with other conventional imaging, such as a CT scan, to make sure that indeed we are seeing metastases or not. This is just another example. You can see on this coronal CT scan, you've hopefully pointed out there is a big mass in the left upper lobe for this patient. This is likely to be any number of things, but most probably is going to be a primary malignancy. So one of the treatments for this might be radical treatment. The surgeon may want to go and resect the cancer, but we need to do some form of staging first. So this is an Fdg Pet Ct scan. It is essentially a way of imaging sugar, because one of the things we know about cancer is it likes to eat a lot of sugar. So if we give a radioactive sugar, hopefully it will light up. And it's very important when it comes to staging, because the surgeon will want to know, are there any other sites of disease? If they only took out the lung cancer, and it turns out that there is a liver metastasis, that treatment may be quite futile and the patient might have benefited from more systemic treatment. So if you remember from this case, we can only see a lung nodule. But on the PET-CT, we can see the lung nodule lights up quite nicely on the PET-CT scan, very much in keeping with the cancer. But we can also spot two other sites of increased uptake in the mediastinum, and these actually relate to lymph nodes. So the scan has been able to pick up additional sites of cancer that may not have been picked up on anatomical imaging alone. And that essentially is what nuclear medicine or functional imaging is about. Whereas anatomical imaging, such as CT, is giving you the answer of where is it and potentially what is it, functional imaging or nuclear medicine is basically telling you what is the lesion doing. So how does it all work? This component of the talk is going to cover more of the scientific and practical aspects of nuclear medicine as a whole. And if we start right at the basics, hopefully this is familiar to you, and this is indeed an atom comprised of a nucleus made up of protons and neutrons with many orbiting electrons surrounding it. And the nomenclature that we will have for the atomic structure will be made of the atomic number, which tells you how many protons are in the nucleus, the neutron number, which is the number of neutrons, and the mass number, which is the combined sum of the number of protons and neutrons within the nucleus. And if you ever looked at an element on the periodic table, the usual display might be the top number representing the mass number, i.e. the number of protons and neutrons, and the atomic number below, which would reflect the number of protons. And many elements, all elements in fact, can have many different isotopes. And an isotope is essentially the same element with a different arrangement in its nucleus. It will be a different number of neutrons. So you can see in this top example, this atomic structure of an arbitrary element has 3 protons and 3 neutrons in its nucleus. Whereas an isotope of this particular element is missing a neutron. So one isotope can have 3 protons and 3 neutrons with an atomic number of 3 and a mass number of 6, whereas another isotope could have 3 protons and only 2 neutrons. The atomic number is still the same because we have the same number of protons, but the mass number is lower. It's now a mass number of 5 as opposed to 6. And this is quite important because isotopes can be stable or unstable, and an unstable isotope tends to be called a radioisotope. An isotope is one of the main building blocks of nuclear medicine. In fact, in the olden days, we used to be called radioisotopes even. And there are lots of isotopes of lots of different elements, and they all have many different clinical applications. Just to give you an example, iodine-123 is a low-energy gamma emitter, which we can use to diagnose thyroid cancer. Whereas iodine-131 is a much more potent high-energy beta emitter, which we can use for treatment of malignancies such as thyroid cancer. Gallium-67 or Ga-67 is a very old tracer that we used to use many years ago for investigating infections, particularly in the middle ear. Whereas Gallium-68 is a modern PET tracer that we are using for diagnosis of neuroendocrine cancer and prostate cancer. But you can see by just changing the mass number by 1 has very profound effects on the clinical applications of a particular isotope. And when we talk about different isotopes, essentially unstable isotopes are trying to reach a form of stability. So a heavier nuclide may need more neutrons in order for it to become stable. Whereas if it's able to gain a few more neutrons to reach a point of stability, then it would have to do that via some sort of radioactive decay. So to basically summarize that, in order to become stable, an isotope must undergo some decay. So here's an arbitrary isotope. It's quite unstable because it's got 3 protons, it's only got 2 neutrons. It's missing a neutron, so it's unstable, and one of the ways it might be able to do that is to break down this proton into a neutron. So in doing so, it has been able to become stable. But if quantum thermodynamics has taught us anything, nothing is free. So in order to get to this more stable energy state, some energy has to be emitted. And it's usually in the form of radiation. And emitted radiation are of 3 most common forms. They could be alpha emission, which is essentially a helium nucleus made of 2 protons and 2 neutrons. It doesn't have many uses in medical imaging or treatment. Beta emission, which is just either an electron or a positron. Again, not many direct uses in imaging, although we can use it in PET imaging, which we'll cover on a bit later in the talk. But gamma imaging is the radioactive emission that we are most interested in nuclear medicine. This is the best for imaging. And gamma emissions are effectively photons of the electromagnetic spectrum with an energy very characteristic of the originating radionuclide. And in stasis, it has no charge or no mass and is generally associated with 1 or more forms of decay, in which the excited nucleus, as I showed earlier, was trying to get to a more relaxed ground state. And it has many imaging applications, many non-imaging applications, and many therapy applications as well. So gamma energy is what we're really trying to harness from radioactive decay. So as I mentioned, in nuclear medicine, the patient is the radioactive source, and they are emitting radiation that we are trying to harness in one way or another. And with X-ray, the radiation is coming from outside the patient. But let's think about the practical applications of this. Nuclear medicine cannot be switched off. Once you have a radioactive substance, it continues to decay and continues to emit radiation until there's nothing left or it's expelled from the system. Whereas in X-ray and CT, it's controllable, it can be switched off. So if a patient comes for a CT scan or an X-ray, once they've had the X-ray or the CT, nothing's changed physically to the patient. They're still the same before they came into the department. Whereas in nuclear medicine, say if a patient has come for a PET scan or a bone scan, we've injected them with a radioactive substance. So now, even after we've acquired our images and are finished, the patient is still radioactive. And so this leads on to other implications. Because we cannot switch off nuclear medicine, well, how does the patient stop becoming radioactive? They can't stay radioactive forever, obviously. Well, part of it is also how the patient is able to expel the radiopharmaceutical from their body. In this example with a bone scan, they will likely try to expel the radiation through urine, so it will be excreted by the kidneys and into the bladder. But of course that means if the patient passes urine, it is radioactive. So the patient cannot just go and urinate in any old bathroom, so we would have a special, what we call hot toilet in nuclear medicine that the patient would urinate in. But say if the patient has a leakage and they contaminate their clothes that they're wearing, well, those clothes will remain radioactive as well. So how do you manage that? Other practical considerations is that, say we have made our radiopharmaceutical in the pharmacy at about 9 AM, and then we go to inject the patient a couple of hours later at say 11 or 12 AM. Well, how much radioactivity are we injecting into the patient? Because all the while this radioactivity is decaying, so you won't have as much radioactivity earlier in the day as you do at the end. Other practical considerations might be safety for the patient and staff as a whole. So say we have a patient who has had a PET scan and a radiologist wants to go and do a biopsy immediately after, or a surgeon wants to take them very quickly into theatre. Their patient is still radioactive. There's still a lot of radioactivity in that lung lesion. How long can you wait before it is safe to intervene without giving yourself a big dose to your fingers? And then of course for the patient, they need to limit contact with family members or young children, or even staff or members of the public, because remember, while they are still radioactive, they are emitting radiation in all directions. So the radiation protection of the family and others that the patient may be come in contact with is also quite important. So how do we manage this? Well, you have to understand a little bit about activity, and that entails the radioactivity of a sample can be measured as the number of decays per second, as in how frequently a nucleus is decaying to a more relaxed ground state and releasing radiation. And the general accepted units is the becquerel. 1 becquerel equals 1 disintegration per second. So say I have a group of radionuclides. So decay is a random process in that I do not know which nucleus is going to decay at any one time. But for large numbers of nuclei, we can predict the form and rate of decay. So over a set period of time, I might be able to predict what proportion of these radioactive nuclei are going to decay at a set point over time. And this is because decay is exponential. The rate is determined by a decay constant, i.e. the likelihood of decay in a given time over units. And it's a bit of a curve like this. And isotopes decay with a characteristic half-life. And this is important. The half-life is the time for half the nuclei to undergo decay. So let's just give an example. So I have a made-up element of an isotope, okay? And I've got a set number of radioactive nuclei. If I wait to see how long it takes for the number of nuclei to decay by half, based on this element and this curve, I'd have to wait 2 days. Okay, for it to halve again, I might have to wait another 2 days for that to go away. And for it to halve again, I only need to wait another 2 days. So you can see it takes 2 days each time for the radioactivity of a particular isotope to drop by half. So the half-life is 2 days. So the half-life is going to vary depending upon what kind of isotope you're looking at. Now this was just a made-up isotope with a 2-day half-life. But let's put this into practice. So this is a technetium whole-body bone scan that the patient has had. The half-life of technetium is 6 hours, i.e. it takes 6 hours for the radioactivity to drop by half. Now, say you have an instance where the patient has urinated their clothing on the ward. They've just had an inpatient bone scan. Well, how long is that clothing going to stay radioactive? Well, we know the half-life of technetium is 6 hours. So that means in 6 hours it would have halved. In another 6 hours it would have gone down by a quarter. And in another 6 hours it would have gone down to an eighth. So essentially, by about 24 hours, most of the radioactivity would have gone. We can also use the half-life curve to ascertain how much radioactivity we're giving at a point in time, because we can plot it on the exponential curve. And in this example, this was a F18 Fdg Pet Scan, a standard PET scan. The half-life of fluoro-18 is 110 minutes. So a patient has had a PET scan and you want to know how long can I wait before I can start doing things like intervention. Well, if you waited 110 minutes, the radioactivity would have halved. So even if you've waited as long as 6 hours, the radiation or the radioactivity would have dropped down by a significant amount. Of course, we're talking about physical half-lives, not effective half-lives. There's also accounting for how long it takes the body to excrete it as well as the radioactivity. But this is really just to give an overview over the importance of knowing the half-life of the isotope that you are using if you are trying to do a particular imaging process. And if we're talking about radioactivity, we can't talk about radioactivity without talking about dose. So the natural background in the UK is on average about 2 to 2.6 millisieverts a year, depending upon where you live. Now, to put that for comparison, A chest X-ray has a dose of about 0.1 millisieverts. That's the equivalent to about 4 hours on a flight. A CT head might have 2 millisieverts. A CT thorax could range from 4 to 5 millisieverts. A whole body bone scan using 600 megabecquerels of technetium will give a dose of about 3 millisieverts to a patient. And a PET scan, you're looking as high as 8 millisieverts. Nuclear medicine tests tend to be some of the highest radiation dose tests that you can do in a hospital. And it is for that reason it is very heavily regulated by usually a body such as the RSAC committee. And so only certain individuals or their delegates may be allowed to actually authorize these sorts of scans. So the other thing we need to talk about again is the radiopharmaceutical. So as we said, the main thing about nuclear medicine is we are taking a radioactive isotope and attaching it to a compound of interest to try and image a particular biological process that we are interested in. And we can introduce that via IV, an oral capsule, an inhaled vapor, or even mixed with food. Now, the most commonly used radiopharmaceuticals are actually based on the technetium-99m isotope. It's a very versatile isotope, but there are other ones out there that we use in conventional nuclear medicine, such as indium, iodine, gallium, and selenium. But for the purpose of this talk, we are going to focus mainly on technetium because that is the most commonly and widely used isotope. And the great thing about technetium is that we can attach it to lots of different compounds to look at lots of different imaging processes. So here are some examples. So the top left one is a DMSA scan. So we might use that to look at things like renal cortical scarring, renal function. Say if a patient is going to have a nephrectomy, the surgeon may want to know how much functioning kidney is going to be left before I go and chop it away. This is a defect on a technetium MAA scan. So this has been done to look for pulmonary embolism on a VQ scan, and we've injected the patient with MAA or that has been labeled with technetium, and where the arrow points is a segmental perfusion defect in the right lower lobe, which is quite typical for a pulmonary embolism. And the benefit of this test is it's actually a very sensitive test for PE with a much lower radiation dose compared with the CTPA. This is a Sestamibi scan, so this one has been done for cardiac imaging. So patients that are in the moderate risk group of coronary artery disease, we might want to look to see is there a significant inducible ischemia that warrants a trip to the angiocatheter lab. So you can see with the green arrows there is normal uptake in the left ventricle during rest. Whereas when we put the patient under stress by making them run on a treadmill, for example, and then we image their heart after that, you can see that there are big sites of reduced uptake at the apical and the anterior and septal walls, very indicative of inducible ischemia in the left anterior descending artery territory. So we would tell the cardiologist that is where they need to target their stenting. This is an example of parathyroid adenomas. HDP, MDP, is effectively a radioactive phosphate scan looking for bone metastases, which we discussed earlier. This is an example of a HMPAO scan. So with patients with conditions such as Alzheimer's disease, they might exhibit specific sites of cerebral hypermetabolism, for example, in the parietal and lateral temporal lobes or precuneus. And this is quite a nice test for identifying metabolic dysfunction before you see the anatomical structural dysfunction on imaging such as MRI. So where do we get this technetium from? Well, it starts in a reactor with something called uranium-235 that might undergo neutron bombardment, and then this forms molybdenum-99, which is, through beta decay, becomes technetium-99m. This is the isotope that we really want to use for our imaging. But technetium-99m will continue to decay into technetium-99, and in getting to this more stable form, it releases the gamma energy that we are trying to pick up to do our imaging. Technetium-99 then decays into ruthenium, and whereas technetium-99m has a half-life of 6 hours, its daughter product, technetium-99, has a half-life of over 211,000 years, which is nearly as long as this talk. So for the purposes of imaging, we are obviously very interested in harvesting technetium-99m, but where can we get it from? Well, I don't really fancy keeping much uranium-235 near my office, so molybdenum will have to do. And that is quite convenient because it is immediately above it in the chain in terms of decay. So how do we get it? Well, most nuclear medicine departments have what is called a generator, in which we have a molybdenum-99 column that is continuously decaying into technetium-99m. And all we do is we just pump some saline through the column in order to get the technetium that is decaying within the block. We can then take this technetium-99m out of the solution and mix it with our kit to use it for all the different things we want to use it for. But as we go through the week, there's less and less molybdenum available, so there's less technetium that we can get from the block. So this means that every week we need to replace this generator. It also means at the start of the week I can do lots and lots of bone scans and VQ scans, but on a Friday at the end of the week I can barely scan anything, which is fine by me for an early finish. And as you can see, these are all the different products that we are using that we've labelled with the technetium-99 that we've managed to suck out of our generator and use them in all sorts of different ways. As I usually tell people, give me a vial of technetium and I can tell you pretty much anything about a patient. So now we are moving on to PET-CT, or positron emission tomography. It has several similar things to the other kind of nuclear medicine imaging we talked about before. It is essentially still using radiopharmaceuticals for functional imaging. But PET-CT uses a very different kind of isotope. It uses specifically isotopes that are called positron emitters. Positron emitters are very high energy releasing gamma emitters, essentially. And because of that, you can't really do a PET scan on a conventional nuclear medicine camera. You have to use a special kind of camera if you want to image PET tracers, which is why we get a PET CT scan. And in the PET CT scan, a patient can have a PET scan and a CT scan on the same camera. So this is our conventional nuclear medicine camera that we might use for imaging bone scans and gastric emptying scans and kidney scans. And it's quite a good camera for using isotopes such as technetium or iodine or indium. And as you can see, it's made of just 2 gamma detectors. But this is a PET CT scan, which is a bit more of a sophisticated piece of equipment. So it is comprised of a PET component, which essentially is a big ring of detectors that surrounds the patient, and it is comprised of a CT component. So the patient can have their PET scan and then immediately have their CT scan on the same camera. So how do we get the PET images? Well, if we go back right down to an atomic level, so PET tracers are isotopes that are deficient in neutrons, and they are quite unstable. So in order to get stable, it tries to break down a proton into a neutron to make up this deficit. But by becoming stable, it has to give something up. And in this case, PET tracers emit a little thing called a positron. It is essentially like an electron, but it has a positive charge instead. And when this positron is released and gets flung out, it might start to collide with an orbiting electron in an adjacent atom. And when it collides with an adjacent electron, it forms an annihilation. They annihilate. And at this annihilation, what gets released are 2 gamma photons, perfectly perpendicular to each other, released in opposite directions. And this gamma photons have an energy of 511 kiloelectron volts pretty much every time. So when these gamma photons are released from the annihilation, they are leaving the patient in opposite directions, and they reach opposite ends of the detector rings at the same time. And when they do, it's called a coincidence, and this coincidence gets registered on an imaging matrix as a position. And this happens thousands of times in lots of different directions to create a series of points to help formulate, eventually, after thousands and thousands of projections, a 3D image. And this is our 3D PET scan. This takes about half an hour after injection of isotope and the patient lying in the camera in order to achieve this image. So we now have our PET image. So as soon as the patient has had that, they immediately get put further through the ring and we acquire our CT component. We take the PET image and we combine it with the CT image to create a fused PET CT. And this is what hybrid imaging is all about. We've got the functional information of the PET scan and the anatomical information from the CT scan to give a very sensitive and specific test. And this is one of the forefronts of imaging in medicine as a whole. And there are lots of different PET radiopharmaceuticals out there for all sorts of different uses. But for the purpose of this talk, we're going to concentrate on F18 Fdg. This is the most commonly used PET isotope in the UK and has a wide range of uses, and it is very important to become familiar with this. So fluoro-18 Fdg is, in the long term, fluorodeoxyglucose labelled with a fluoro-18 isotope. So fluoro-18 is the positron emitter, and it is essentially a fancy way of imaging the biodistribution of sugar in the body. And so it has got very good applications for imaging cancer. So here is a cancer cell, and the thing with cancer cells is that they tend to express a lot of receptors called these GLUT1 transporters. This facilitates the cancer cell to eat a lot of glucose. Cancer cells want to grow as big and as fast as they possibly can, and in order to do that they have quite an appetite for sugar, so they want to eat as much sugar as they possibly can. So we think, well, let's take some sugar or glucose, and why don't we label the glucose with something radioactive like fluoro-18, so that once it's injected into the bloodstream, this radioactive glucose will get attached to the GLUT1 transporters of the cancer cell and will get internalized. And in doing so, when it eats the glucose, it's inadvertently taking in the radioactive isotope, which is emitting its gamma photons. And these gamma photons being emitted allow us to pick it up on the scan. So you can see on this PET CT scan, you've got sites in the body that normally use a lot of sugar anyway, and so will be hot on the PET scan. So your brain is normally very hot. That's why, because the brain eats a lot of sugar, that's why you tend to get quite hungry after a long revision session. The left ventricle of the heart is very hot because that does a lot of pumping, and the liver can be quite warm as well. But what you can also see on this scan are these hot spots in the neck and in the abdomen with the yellow arrows, and these signify the cancer cells that have also decided to eat a lot of this radioactive sugar that we've injected into the body. As I've said, there are a lot of indications for PET CT and they're growing every day. At the time of this lecture, this is the most up-to-date available document for the indications of PET CT in the UK. It has been done in collaboration between the Royal College of Physicians and Radiologists. It's a very useful document to give you an overview of the uses of PET in clinical practice. But to summarise the indications, and there are many, it is particularly useful for imaging cancer. So PET CT can be used to stage cancer, which can potentially be treated radically. So if you remember with our case, the left upper lobe lung cancer, which is showing very hot uptake on the PET scan, and is also being found nodal disease as well that you might not have picked up with other imaging. So a PET scan is very good for that kind of baseline staging, because a PET CT can find other sites of disease that you might miss on other imaging. And remember, if you do find metastatic disease, the patient may not be able to have curative surgery. So it's very good as a baseline staging as well before commencing treatment as well. It's very good for characterizing indeterminate lesions too. So this is an example of a lung nodule which doesn't show any uptake on the PET scan and turned out to be benign. It's also good for assessing response to therapy. So in patients with lymphoma, we like to do a PET scan before treatment, and what you find is that when you treat the patient with chemotherapy, you will see a metabolic response before a structural response. What that means is that the disease will get cold on a subsequent PET scan before it shrinks on a CT scan. So a PET scan is very good for assessing the overall prognosis of a patient and their response to treatment. If the disease remained very hot even after the patient's had treatment, then that patient's got quite a poor prognosis. PET-CT is also good for looking at suspected disease recurrence or relapse or residual disease. So sometimes when you've had treatments, it can be a bit difficult if you see a blob on the CT. Is it truly disease or not? But a PET scan can sometimes help you with that. It's also good for helping identify a suitable biopsy target as well. So again, with this example, yes, we can see that there is disease in the abdomen and the pelvis. And we can also see there's disease in the neck. So if we needed to get a histological sample with a needle, it is much easier to stick a needle in the disease at the neck than it would be in the middle of the abdomen. It can also help determine a suitable biopsy target. So you can see there is a large malignant football in this patient's abdomen, and you can see peripherally it's quite hot, but centrally it is quite cold. And this is usually because the cancer is quite necrotic in the middle. It's mainly just sort of almost water in a sense. So if you try to do a biopsy and you place your needle in here, you are unlikely going to achieve a diagnostic pathological result. The pathology result might be equivocal. If, however, you chose to target your biopsy more peripherally, where we know it is hot on the PET scan, you're likely going to harvest a positive sample of cells. So this is clearly the best place if you're going to target doing a biopsy. PET is also good as a problem-solving tool. It can help find occult primary cancers that you may not have been able to find on other modalities. It can evaluate suspected recurrence where previous CT or MRI imaging might be equivocal. It can look to see if there's malignant transformation, for example in CLL or neurofibromatosis, a lesion that is usually cold that suddenly becomes hot on a PET scan might indicate a malignant transformation. It can differentiate between radiation-reduced necrosis and tumour recurrence. They can both look quite similar on a CT scan, but radiation-induced necrosis will be cold on a PET, whereas tumour recurrence will be hot on a PET. And it can also be used to detect a source of infection or inflammation. So this patient in the example on the right, they had a history of recurrent pyrexia and elevated inflammatory markers. A swab was put in every hole and a CT scan was performed and they were all negative. However, we did a PET CT and you can see that the aorta and its branches are lighting up like a postmodern Christmas tree. And this actually turned out to be a large vessel vasculitis, more specifically Takayasu's. So the PET scan is very good when you have got patients with pyrexia of unknown origin to help try and identify a source of inflammation, because it's very sensitive actually. So in conclusion, there are many clinical applications for investigating disease with nuclear medicine and PET-CT. We are essentially taking a compound of interest, labeling it with a radioactive isotope, and we are introducing it into the body so that we can image a sort of biokinetic process or pathological process of interest. And so this example here of imaging with the biokinetics and disease process of interest in the case of lymphoma with an Fdg Pet Ct. Remember, the patient is the source of radiation. This means that once injected, it cannot be turned off, i.e. the patient remains radioactive until the radioactive product has decayed sufficiently or it has been cleared by the patient's body systems. And if it has been cleared by the patient's body systems, then whatever waste product will still be radioactive until it has decayed by the appropriate exponential function as we've shown earlier. So of course this has impacts on radiation safety, and of course for patients radioactive they need to maintain appropriate distancing between friends and relatives and staff, depending upon how radioactive the substance they've been given is. And this concludes the nuclear medicine and PET CT talk.